We start with the third question. We have a 20-year-old woman who is 32 weeks pregnant, present to the emergency department with vaginal bleeding and abdominal pain for the past few hours. Her observations are heart rate of 110, BP of 90-50 and respiratory rate like around 24 per minute. On examination, her abdomen is quite tender and feels very tense and woody on palpation. What could be the possible diagnosis?
So here it's a gravid lady with more than 24 weeks of gestation presenting with a bleeding PV, and from the description of the woody consistency of the uterus and or it's diagnosed as diagnosis abruption placenta.
Okay.
It is placental abruption.
Placental abruption. So what could be the difference between placental abruption and placenta previa in this case? Why do you say this could be leading to the diagnosis of placental abruption mostly?
So more than 24 weeks, the major cause of bleeding PV is either of the two, that is an abruption placenta or the placenta previa. So mainly how to differentiate is then mainly in means of pain. In placenta previa it's a painless bleeding, while an abruption it is possibly a painful bleeding. And second thing is the consistency. In placenta previa uterus will remain soft, otherwise in the abruption placenta the uterus will remain tender, sir. And next one is the in view of fetal distress. In placenta previa the fetal distress may not be there, but in abruption fetal distress possibility is very high. Next is the correlation between the shock and the amount of the revealed bleeding.
Okay.
In placenta previa the amount of bleeding is almost in correlation with the hemodynamic stability of the patient.
Yes.
While in the case on abruption, chance of that it is not consistent with the hemodynamic stability of the patient, because it can be either a concealed or a revealed type of abruption.
Yes. So what are the risk factors which could be leading to this diagnosis?
Okay, again the risk factors for abruption placenta and placenta previa is almost same, but difference are there. So since it's a diagnostic case of abruption, first I will say the risk factors for abruption.
Okay.
Major risk factors are any previous history of any abruption placenta, the patient is having a history of any smoking, or a patient is having any history of multiparity, that is the patient is having already history of multiparity, previous history of LSCS, the patient is having already a pre-eclampsia, patient is having any history of trauma. These are the major risk factors.
Yes. Any behavioral habits which can lead
smoking,
to smoking. Excellent.
And now coming to placenta previa, again the risk factors are any previous history of placenta previa, again any history of a previous LSCS, the patient is having an abnormal uterus, or the patient is having increased parity, or the mother increased maternal age, it's also a risk factor. And any history of any ART technique,
yes, assisted reproduction techniques,
has been used. Or
yes. Okay. So give me 4 steps, or maybe like you can illustrate what are the steps which you can tell me how do you manage this case in the emergency department?
Management, again first and foremost we have to secure the IB line.
Yeah. So we start with ABCDE approach.
Of course the ABCD part has to be taken care.
Yes.
ABCD approach has to be taken.
Yes.
And other than that we will have to secure a large bore cannula.
So before that there is one more thing. There is an absolute contraindication in this case. What should not be done? So per vaginal examination should never be done. Yes, that should be noted. Yes.
Other than that, we have to secure a large bore cannula has to be secured. Relevant investigations like cross matching of the blood along with the RH compatibility, and the food blood count, the urea and the electrolytes, and the coagulation profile.
Yes, fibrinogen also has to be sent.
Fibrinogen has to be sent, sir.
Okay.
Then at least a 6-point PRBC should be arranged, and the immediate obstetrics and gynecology team should be informed.
Yes.
And other than that, an antiemetic analgesic should also be offered, fluid resuscitation should be offered, should be given, and as soon as the PRBC is available we should transfuse the PRBC also.
Okay, so you tell me like what are the so what does this antepartum hemorrhage means? How do you define antepartum hemorrhage?
Antepartum hemorrhage is any gravid lady post 24 weeks of gestation coming with a bleeding PV. We can take it as antepartum hemorrhage.
Antepartum. As you told, there are two main causes, placenta previa and placenta abruption. So, give me some details about placenta previa. What do you mean by this placenta previa means?
Placenta previa is whenever the placenta is occupying in the lower half of the uterus, and that to itself there is a major
Lower segment of the uterus.
Yeah, I mean lower segment of uterus, and that itself there is a major type and minor type.
Yes.
The major type means the placenta previa is occupying above the internal os of the cervix, so it is considered as a major placenta previa. And if it is only the brim or the partially only covering the internal os, then it is considered as a minor type of placenta previa.
Yes. So we have covered the definition. We have covered the risk factors also. So you have told about placenta previa. So what about placenta abruption?
Abruption is actually again already the placenta is in the normal location, but there is a premature detachment of the placenta from the uterus. Again, it's of two types: concealed and revealed.
Yes.
Concealed means they may not be enough bleeding revealed outside, but the center part may not be detached from the uterus. But revealed type means that the bleeding will be profusely noticed outside.
Yes. So which I think revealed is the one which is the most common type of abruption placenta.
Yes,
so so there is something called as when a patient comes with a history of vaginal bleeding, continuous abdominal pain, uterine contractions, the patient being in shock with fetal distress, you should always suspect abruption placenta, and on examination the patient should have a very tense, rigid abdomen with woody feel, and patient definitely is in distress, and even the fetus also in distress. So one thing which has to be told in the management part, apart from managing the mother, we have to manage the fetus also. So fetal monitoring will also has to be accompanied with the whole treatment panel of what we are doing in the ER.
Along with that, if the mother is Rh negative, we can give a shot of anti-D also.
Anti-D also, yes. So this completes the presentation of the day.